Atrial septal defects are among the most common forms of heart defects. They occur in 7% of infants born with congenital heart disease. It is an abnormal communication between the two atria that can be found in various positions within the atrial septum. Four types of atrial septal defect are known, according to their position within the atrial septum. The ostium secundum defect is the most common type of interatrial defect and occurs in the center of the atrial septum within the oval fossa. The ostium primum defect occurs in the lower part of the atrial septum near its junction with the interventricular septum. The ostium primum defect is classified as an atrioventricular septal defect as well. The sinus venosus defect can be located at the orifice of the superior vena cava, the so-called superior sinus venosus defect, the most frequent one, or at the orifice of the inferior vena cava, the so-called inferior sinus venosus defect. The coronary sinus defect is located in the mouth of the coronary sinus, thus creating a communication between the coronary sinus and the left atrium. Atrial septal defects usually allow blood flow from left towards right, causing a left-to-right shunt. The direction and magnitude of the shunt are determined by the size of the defect and atrial pressure. Persistent large defects may lead to pulmonary hypertension and pulmonary artery vascular disease in patients over the age of 20 to 30. Clinical aspects of atrial septal defect depend on the size of the defect. Children usually have no symptoms, or they may present only vague symptoms like retarded growth, recurrent respiratory infections, and fatigue. Infants with large atrial septal defects or older adults may present signs of heart failure. Auscultation may reveal a systolic murmur at the pulmonary area and splitting of the second heart sound. The most useful methods of diagnosis are electrocardiography, ECG, chest radiography, echocardiography, cardiac catheterization. Electrocardiography usually reveals right bundle branch block and signs of right atrial enlargement. Chest radiography, in those cases with large defects, shows cardiomegaly with both right atrial and right ventricular enlargement and increased pulmonary vascular markings. Echocardiography usually allows a comprehensive diagnosis of all types of atrial septal defect. Sinus venosus defects often require cardiac catheterization and angiography. This is a large ostium secundum defect, shown on the apical four-chamber view. Color flow mapping shows the left to right shunt and both right atrial and right ventricular enlargement. Cardiac catheterization may be useful in those patients with severe atrial septal defect or when pulmonary vascular resistance needs to be measured. Atrial septal defects usually require early surgical correction. Rarely, atrial septal defects close spontaneously. Nowadays, percutaneous intervention allows repair of atrial septal defect with placement of a closure device during cardiac catheterization. Percutaneous intervention is now the procedure of choice for ostium secundum defects, while ostium primum and sinus venosus defects still require corrective surgery. Patients who present evidence of pulmonary vascular disease and of reversed shunt, i.e. right to left, should not undergo surgery. Open heart surgery under extracorporeal circulation is performed to repair the atrial septal defect. The surgical approach may be performed either through median sternotomy or right thoracotomy. The defect is repaired by suture or with placement of a pericardial or other patch through the right atrium. The catheter is inserted through the femoral artery and advanced up into the right atrium. Finally, it is pushed through the atrial septal defect into the left atrium. The distal disc is opened into the left atrium and the device is retracted to deploy the disc in the defect. Finally, the proximal disc is opened into the right atrium and the guiding catheter is retracted in order to deploy the disc.